Okay, Dr. Khalid, you can start.
Okay, Doctor, go on.
Good afternoon. My name is Dr. Abdullah, one of the doctors here in the cardiology clinic. May I confirm your name and age, please? Is it Mr. Still and 75 years old?
Yes, that's him, Doctor.
Hello, hi, Mr. Still. How are you doing today?
It's okay. Nice day. Thank you.
I believe, Mr. Still, that we are here to discuss about your medical condition. Is that okay?
Okay, Doctor. Welcome.
Mr. Still, do you want anyone else to attend this conversation?
No, Doctor, it's okay. I can manage.
Okay, fine. Mr. Still, how much do you know about your current medical condition?
Yes, Doctor. You know, for the last 7 years or 7 years ago, I had this cabbage operation because I had problem in my bloody channels. Then after this, I started to have shortness of breath. It was not severe, but by time it started to be more severe. I was admitted to the hospital many times. Last time maybe 3 months ago, and every time they increase the medications for me. Last visit, they told me that now I reached the maximal number of tablets that I can receive for my heart problem, because I know that I'm having a heart failure. So I received a call 3 days ago that they want me to come and attend a meeting to discuss another treatment option. So that I am here today.
Of course, Mr. Sir, I appreciate your concern. Actually, I was asked by my consultant to discuss with you a new line of treatment that you are a good candidate to have, which is called a CRTD, a cardio resynchronization therapy and defibrillation. Did you hear about this before?
No, Doctor.
Do you want me to go on and explain more about it?
Yes, please.
Okay, Mr. Sell. Mr. Sell, this type of treatment usually is indicated in patients like in your condition after being on the maximum optimal medical therapy and still suffering from shortness of breathing and poor heart performance. So this kind of treatment is like a device that has been inserted with wires to your heart, helping your heart to pump more blood, I mean effectively more blood, and to decrease the incidence of any arrhythmia. And of course, it will decrease the rate of hospitalizations and improve your quality of life. And if you allow me, I can just draw like a diagram, a simple diagram illustrating this device while inserting to your to the heart, and this is the wires in your heart chambers, improving the contractility of your heart chambers, and in turn improving the performance. So it will decrease mostly significantly the symptoms of heart failure like orthopnea, like this shortness of breathing and swelling in your legs and easy fatigability and the sensation of weakness all over. And before, are you with me, Mr. Still?
Yes, I'm with you, doctor.
So usually before doing like this procedure, we are going to ask for some blood tests and scan your heart and chest and make sure that there is no. I mean, you are now taking blood thinning medications like aspirin or Plavix for sure. So we will make sure that this medication will be held before going for this such procedure. And of course, we will offer you a consent to be signed if you agree to proceed in such procedure. And this consent will contain all, will document all the conversation between us with the risk and benefits of this procedure. And of course, if you change your mind, you can cancel this consent at any time before the procedure, of course. Are you following me, Mr. Still?
Yes, doctor, but because you gave me lots of information, I can remember now that you said you will insert some wires inside my heart.
Yes,
how it comes?
exactly. It's gonna be under a device like X-ray device, showing these wires being in your heart chambers, and these wires will help you will help your heart to contractile in a concordance with your heart electricity as well. Is that clear enough, or?
Yes, doctor, but you said wires, you know, and how can you insert wire in the flesh of my heart? It may cause prick for me.
Okay, I appreciate your concern. So let me proceed and draw more about this procedure and this wires. It's like a device with two wires attached to your heart chambers, and this device will produce some electric signals to this ventricle. I mean this chamber to help for better contractility and as well prevent any disturbance in your heart with causing the symptoms of fatigability and shortness of breathing. So I believe you will be under anesthesia during this procedure. So one of the anesthetic doctors will help
What's
you.
What's anesthesia, doctor? What is this word, anesthesia? What does it mean?
You know this. This kind of while doing any surgery or operations, you will be under the effect of medications that make sure you will not feel any pain and keep comfortable and sleepy during the procedure. Did you get me?
So you will give me a medication that will not make me feel the pains, yes?
Yes, usually there's anesthetic doctor gonna be present during the procedure and make sure that you will not feel any pain or discomfort.
But I will be awake, doctor, or will be sleepy during this?
It depends. It depends, actually, Mr. Still. Sometimes you will just receive some sedative drugs that if you feel worried or anxious somehow, so we can give you some sedating drugs, and it's not like a deep anesthesia or something like this. I mean a deep kind of medications this medication that can cause deep sleep, like in other surgery.
Okay.
So let me assure you, Mr. Stell, that we have a lot of experts here in our hospital doing this procedure, hundreds per year, without any significant complications or drawbacks. But like any procedure, there is some possibility of complications during the procedure. Like a disturbance in your heart rate during the procedure, or sometimes a bleeding around the heart. But let me reassure you that we will be ready for this type of complications if happens, which is actually a very low chance to happen. If any bleeding, we will carry a blood transfusion for you, and you will be kept in the hospital till everything gonna be okay. And after completing the procedure, I think you will need to be in the hospital maybe for usually 1 day after the procedure, making sure that everything is fine and no complications or side effects from the procedure. But are you with me, Mr. Stell?
Yes, doctor, I'm with you.
But let me confirm with you that if you developed any kind of pain or chest tightness or pallor or shortened breathing, so you need to come to the emergency department or contact us. I'll give you a discharge letter with the contact numbers for the department and the hospital.
2 minutes remaining, doctor.
You can contact us anytime, Mr. Stell. And of course, you will need, we will arrange you a follow-up appointment in the next few days. Mr. Stell, any concern from your side?
Yes, doctor. When you are going to remove this device, you told me that you will insert it. When you are going to remove it?
I appreciate your concern, Mr. Stell, but this device will not be removed, but it will need a regular checkup with the department. And this device has a battery which gonna be changed according to the type of the device. Sometimes after 5 years or 10 years, this lifespan for this battery. But this device will not be removed. It's gonna be attached to your heart forever, helping your heart to perform better.
Okay, doctor.
Any concern, Mr. Stell?
So you said it will not be removed?
Yes.
Okay. So how can I live my life if this device inside my body?
Actually, there's a lot of people around, Mr. Stell, having this device just under your skin. This device is going to be attached under your skin, and the wires attached to your heart. So you will not notice this device at all, and you can live your life normally, actually, practicing everything and doing exercise. No concerns from this device at all. Mr. Stell, can I ask you some
time?
Okay, yeah.
Thank you, doctor. 2 minutes for discussion.
Yes.
How was your performance, doctor, in this case?
I think I have managed his concern regarding this device, and I explained the indication and the possible complications, and yeah, I think the whole procedure has been explained to the patient. But I didn't have time to ask for some social history and give him some advice regarding if he's smoking or drinking, and any other precautions post-procedure.
Okay, doctor. So you told him that you will be kept in the hospital for 2 days, yes?
Usually, yeah, 1 day.
Okay. So, doctor, this patient will be followed up in the clinic.
Yeah,
When
of course.
the next time you would like to see him?
I think I'll discuss with my EP consultant regarding the next follow-up visit, but should be in the next few days after the procedure.
In the next
I
few
don't know
days?
exact. I don't know exact time for this.
So, a patient with new procedure and incision, you don't like to see him within 2 or 3 days to have a look on the wound if it's infected or anything?
Yeah, of course, I would like to see him in the next few days. Yeah, but I mean, I don't know exactly 2 days or 3 days or 4 days.
Okay.
I don't know.
Did you tell him that he will take antibiotics for the next few days after the procedure according to the hospital policy?
No, I didn't.
Okay. Did you check if this patient is having allergy to penicillin, for example, if you are going to prescribe a penicillin-based antibiotic for him?
No, I made the drug history and social history actually.
So this patient will have CRTD, yes? You explained well the function of the CRT, but you didn't talk to him in details about the defibrillator function and the risk of cardiac death. Did you inform him that this procedure may fail or he may not respond well to the device you will insert to him?
No, I didn't.
Okay. Thank you, doctor. Thank you, Dr. Abdullah.
Thank you.
Very excellent, Dr. Abdullah, mashallah. I'm so sorry for being silly, but it's better for all of
Thank you so
us
much.
to be like this. Dr. Abdullah, mashallah, in the clinical communication skill, you were accurate, clear, structured, fluent, professional. Apart from specific points we will explain while talking. In managing the patient's concern, you didn't have so much time. I will not say you didn't have so much time. You took too much so that you didn't give time for the patient to tell more concerns. This patient is having more concerns. This patient had a CRTD inserted, okay? So he would ask you about driving. And even if he didn't ask, you should tell him, okay? But the managing the patient's concern, I'm sorry for the, so we said clinical communication skill will be satisfactory. Managing patient's concern, sorry for this, will be borderline. Clinical judgment was okay. You talked well to the patient about this, and you maintain the patient welfare as well. So I think, inshallah, if I'm an examiner, inshallah, you will pass this station with some notes. What are the notes? Okay, now again, Dr. Abdullah, if you attended the previous meetings with us, doctors, please look at the whiteboard. I will write now. I'm going to write now. So, Dr. Abdullah, we said in station 4 scenario, you will receive a blank paper outside. In this paper, you should write 3 arrows. The first arrow, I will have a medical issue here. Then I will have an ethical issue. Then I will have a legal issue. Okay. What was the medical issue in this scenario, Dr. Abdullah?
A 75 years old male with heart failure on optimal.
The medical issue, 2 or 3 words only. The medical issue is heart failure, and I wanted to insert CRT for him. What is the ethical issue in this scenario? What do you think?
The autonomy, the patient has the right to know everything about this procedure and the complication possible, and the benefits that we need to do in the best interest of this patient or the good, and non-maleficence that we doing no harm for this patient.
Okay.
And justice.
Justice will not work here. Justice will not work here.
Of course, yeah.
What is the legal issue in this scenario, Dr. Abdullah?
The consent and driving, of course.
Consent, capacity,
Yes.
and what? You said what?
Driving.
Driving.
Driving. Yeah.
Okay. And here we can type the right of scenario explaining diagnosis. Okay. Before I forget, Dr. Abdullah, this patient didn't agree for the procedure, by the way.
Oh, really?
You didn't ask him if you agreed or no. Okay.
Yeah.
This is the most important point. You know, if the examiner is a good one, he will let you pass. But if he is not, I will not say if he is not a good one. If he is meticulous, he will let you pass because the patient didn't tell you that he accepted or no, and even you didn't ask him. Imagine you did very well, but you missed the last point. You don't know whether your patient will accept or no. Okay, I encouraged you at the beginning, but I have to tell you the truth now. If the examiner is meticulous, he will let you pass this station. So I will tell you something. The problem in communication station, usually we are not trained for communication. We are trained to answer medical questions like what are the causes of splenomegaly, blah, blah, blah. How to treat acute renal failure, blah, blah, blah. What are the indications of aortic valve replacement, what, blah, blah, blah. But here, the condition in station 4 is different. He will not check your medical knowledge. He will ask you very simply, what about your performance? Here, you will get stuck. Why? Because you don't have a medical answer for this question. You are not trained for such type of question. So when you ask you, what was your performance? Or what did you in this scenario, what did you write and what was the wrong things that you did? So tell him, actually, sir, this was a difficult scenario. What makes it difficult? That the patient doesn't know anything about the nature of the device. However, I had 3 issues in this scenario: medical issue, ethical issue, and legal issue. The medical issue, this patient heart failure on optimal medical therapy and needs a device insertion. And the ethical issue, the autonomy, beneficence, and non-malbeneficence. And the legal issue, I need to explain that, I need to take consent from him based on explaining I wrote here explaining the diagnosis, I mean explaining a procedure, sorry, okay? I need to take consent from him based on explaining the procedure. So I had to check the capacity of the patient. I think that he is capable to take the decision and capable and legally he can do the consent himself. And there is also another legal issue, which is the driving. He shouldn't drive for the next 1 month. Here, the examiner will be impressed because you covered all the things, medical, ethical, and legal issues. And these are the fundamentals of communication scenarios. Okay, so when he asks you, what was your performance? The first thing, tell him, actually, sir, this in any scenario, this was a hard scenario. It was not easy. The patient doesn't know anything about him. However, I had medical, ethical, legal issue, and then continue to talk again, to talk about the things as we said now. Okay, then come to the point. I will discuss the medical issue and how to explain a procedure for the patient. You went with the first 6 steps, very excellent. Number 1, you greet the patient. You said, hello, I'm Dr. Abdullah. Then introduce yourself. You said hello and greet the patient. Identify the patient, name and age, very well. Then you make a report with the patient when you told her or asked him, how was your day? Okay. And by the way, don't say how are you or good morning in breaking bad news scenarios. Then you check your agenda You told him you are here today to discuss your condition, and then you asked about his knowledge about his condition. You told him, what do you know about your condition? Then he kept talking to you. This 4, 6, or 7 steps, you did very well. Then come to, doctors, I will erase this and write a new thing. And then come to the point. Whenever you are explaining a diagnosis, doctor, you should cover these points. You should cover these points. Brief description of the procedure. And start with the advantages or the benefits, you know, because benefits usually makes temptation, makes teasing, you know, teasing or temptation for the one to accept. Okay, makes temptation for the patient to accept. Then, after talking about benefits, okay, then tell him who will do the procedure, where it will be done, okay? Then divide the things into 3 arms. Before the procedure, during the procedure, and after the procedure. So let's see what will happen here. Brief description. Okay, what was his name? Mr. Robinson. Mr. Robinson, now you told me you are on optimal medical therapy, and now we are at the last line of treatment, which is called CRTD. Did you hear before about this word, CRTD? And you can write to him, CRTD. He will tell you, no, I did not. Okay, as you did, let me explain to you. So C for cardiac, R, resynchronization, T, therapy, and D for defibrillator. This is the name of the device. It's called CRTD. This is the name of the device. Okay? Then, cardiac for the heart, resynchronization, because you know, Mr. Robinson, the patients like you, if they are having heart failure, the heart is composed of muscle fibers. The problem comes from every muscle fiber moves at its own time, or they don't contract at the same time, so that they will not push sufficient blood to the body. That's why you are feeling shortness of breath and you feel fatigability. This device makes resynchronization, regain the harmony again of the heart, that makes all the muscle fibers, they will contract at the same time, then they will push blood at the same time, then this fatigability will decrease, and then shortness of breath will be improved. This is the first part of the device, so it will improve the symptoms, your symptoms, and not only your symptoms, it may also improve the pumping capacity of the heart, because you know that your heart is weak. Yes, doctor, I know. So mostly it will improve the capacity, the function of the heart as well. You are with me till now, Mr. Robinson? Yes. Till this point, do you want any explanation from the previous ones? No, doctor, it's okay. Okay, let's come to the last letter of the device, which is more important. This D for defibrillation. What do we mean by this? Patients with low functional capacity, low function of the heart, they are, and I am so sorry for this, but I have to tell the truth for you. I will not sweep things under the carpet. People with you which are having this low pumping function of the heart, they are at risk of abnormal heartbeats. This abnormal heartbeats, and I'm so sorry for this, this abnormal heartbeats can end the life very rapidly, even sometimes before the patient can arrive the hospital. You know, it's very dangerous, and we cannot predict at what time it may happen. It's very dangerous. So that, you know, did you watch films before, Mr. Robinson? Yes. Did you see that one came at the hospital and then they gave him like electric shock? Did you see this before in the films? Yes. Okay. This device will do the same, but it will not be in the same manner. So this device contains a sensor inside it. So if it felt any abnormal heartbeat, it will directly give shock to protect your life, because we care about your life and you also care about your life. So till now, everything is okay? You understand till now? Yes, I'm understanding, doctor. Thank you very much. So now it will prevent the sudden heart attack that may lead to sudden death, and it will improve also the symptoms you are suffering from. Okay, Mr. Stewart, does it make sense for you till now? Okay. Okay, so this device, before inserting this device, I need to tell you that it will be done by well-trained heart physician. It's specialized in this area of medicine. He is having a very good hand and well-trained, and we will do it in the catheterization lab. We are having laboratory up in the hospital. Then they will do the procedure in it. It's a day case procedure. So if you did it today, if it was done to you today and everything went smooth, you can be discharged the next day. Okay, Mr. Robinson, you are with me? Yes, doctor, I'm with you. Okay, so let's know what we should do before the procedure. Before the procedure, the patient have to MPO, okay? You shouldn't eat or drink juices for the 6 months before the procedure. And usually we start the procedure at 8 a.m. So it's better to stop eating at 2 a.m. But keep taking your medications. And here, doctor, you made a mistake. You told him we should stop aspirin and Plavix. No, doctor. Aspirin, if he is on aspirin, don't stop it. If he is on clopidogrel, don't stop it. The only one that can be stopped, this novel oral anticoagulants or warfarin. But aspirin or Plavix, we don't stop if the patient is going to an ICD, except if going to CRT, except if this is if this is the consultant opinion. Okay, but usually we don't stop them. So tell him, don't eat 6 hours before the procedure. Number 2, you will need to make shaving of the area. By the way, doctor, you didn't explain to him, if I didn't forget, you didn't explain to him where this device will be inserted. Okay, so we'll be shaving the area of the device, which will be on the upper left part of your chest. You will shave the hair at this area and then take a bath. Then 1 hour before the procedure or 2 hours, you will receive an antibiotic. Despite you are not having a bug, but it's for prevention. I will revise the hospital policy for this, but usually we need antibiotics before the procedure. Is it okay with you? Okay. Come to during the procedure. Okay, see, Mr. Robinson, usually we do it under local numbness. Local numbness here, local anesthesia. Local anesthesia. We don't need to make the people sleepy, and usually we don't need to give them sedative. By the way, sedative is not a medical jargon. But usually we just give them local numbness at the upper left area of the chest, and then put a sterilizing material, and then we make a small, nice incision about 4 to 5 centimeters. And under the skin and under the muscles, you will not feel anything during the procedure. It will be done, and you will be awake. You can talk to the doctors, and you can smile with them. You can say jokes even if you want. You know, you will not be under you will be under only local numbness. And then from this incision, we can get access to a wide bloody channel. Then we can insert 3 soft wires. Don't worry, these wires will not cause breaking to you. So don't worry about. They are very soft, and they are manufactured to deal with the delicate part of the heart. And then these 3 wires are connected to a battery. This battery will be put under the skin. The procedure nearly takes from 1 to 2 hours. And then when we are sure that everything is going okay, we will close the incision, cover it with a tight band. Is it okay with you till now, Mr. Robinson? Did you get everything? Okay. So come to after the procedure. After the procedure, we can give you painkiller. If you felt pain at any time, just contact me or contact the nurse, and then we'll prescribe painkiller immediately for you. And again, you may need antibiotics again after this. I will also revise the hospital policy for this. And I have to tell you very important information. Number 1, don't elevate your hand up above your shoulder level. Don't carry heavy objects with your left shoulder, okay? Don't sleep on your left side. This is in case if we did it from the left side, and usually we make it from the left side, okay? If we did it from the right side, so these recommendations will be to the right side. And as I told you, if everything is okay, we will do X-ray for you after the procedure to make sure that the device in its place, and to check if there is any air leakage. I mean pneumothorax, doctor, okay? To check if there is any air leakage around the lung. Is it okay? If everything is okay, then you can be discharged on the next day. Then after discharging, we will see you within 2 or 3 days just to have a look on the wound and changing the dressing. And then we will see you, and then I will contact my consultant to know when the next time this device needs to be checked. Usually it needs to be checked primarily within the first month, and then every 3 or 6 months. But however, I don't know the exact times, but I will contact my consultant about this. The battery inside may sometimes remain for 7 years, and sometimes in patients and some people remains for 11 years. So it depends on some things. Till now is okay, Mr. Robertson? Yes, doctor. Okay, Mr. Robertson. This is the procedure, and these are the benefits. But to be clear with you, I need to explain also to you the possible drawbacks, the possible complications. We are not dealing with an easy organ. Despite all our organs are vital, I know, but this is the most vital organ in our body. This is the heart. So some drawbacks or some complications may arise, like for example, bleeding at the site of the puncture, or so bleeding, okay. Infection can happen, cardiac perforation, okay, and this cardiac perforation can cause tamponade, and for sure tamponade, you will not tell him tamponade, by the way, I'm just explaining to you, doctors, and tamponade, by the way, can lead to cardiac arrest. This is one of the 5 T's, 5H that causes cardiac arrest. Or arrhythmia can happen, for sure, and this arrhythmia may be fatal and kill him. You have to explain everything for him, and you have to explain the common complications, and the very, very, very rare complication. All complications you know about it, you should explain to the patient. So bleeding is a possibility, contamination with bugs, probability may happen, perforation of the heart, because this wires, despite being so soft, but however, it can injure the heart, and it can make some perforation inside the heart and collection of blood and around the heart. Or abnormal heartbeats can come during the procedure itself, and they may be fatal. I have to tell you everything. But the good thing is that the rate of these complications to happen are very rare, and usually they don't happen. But you should know everything. You should know the good things and the bad things. Is it okay with you, Mr. Robinson? Okay, it's okay. You are agreeing for this? Yes. After finishing, doctor, you have to tell him if there is any alternative or no. Alternative. Mr. Robinson, I have to tell you there is no alternative medication that can do this. This is the only way that can we improve the symptoms and prevent the sudden cardiac death. No medication can do this at this stage. Okay? Okay. The other thing, doctor, you have to mention to the patient the DVLA. He shouldn't drive for 1 month. And again, doctor, if you are not sure about the timing of the patient, how he should stop driving, for how long, tell him, please stop driving, don't drive. I will go back after finishing this session. I will go back to check the DVLA regulations to know the exact duration that you shouldn't drive for the next coming period, and I will come back to you, or I can talk to my consultant, but after finishing this. But till now, the important thing, you shouldn't drive now, but for how long? It's not less than 1 month, but I will come back to you again and to tell you the details, okay? The other thing, doctor, which is very important, you should have asked this patient about a smoking history. You should have asked this patient about alcohol. Both have impact on his heart failure. You should have asked this patient about his job. You know, doctor, he is a businessman, and he is a businessman that is traveling every other week. And patients with traveling, they need what? The card, the doctor, you know? Every patient with insertion of ICD or CRT or a pacemaker, they have a card. Why? Because when they go back, go through the magnetic field, this gate in the airport, the gate will keep alarming because he is having a metal inside his body. So that we give them this card so that he can show it to the security there and tell them that he is having a device. That's why he will be alarming. Okay, this is very important, doctor, to tell the patient. So, Mr. Robinson, I have to tell you something. After finishing, we will provide you with a card so that if you are going through the airports, this device will keep alarming if you went through the gate. So you can show it to the security, and they have idea about such group of people who is having this device. Do you agree for this? Is it okay with you? So till now, Mr. Robinson, you agree for the procedure? Yes, doctor, it's okay. Thank you very much. All what we discussed in this session, it's written in a paper called a consent paper. Just we need your kind signature that you are approving for this. Is it okay with you? Okay. Do you have any concern for me? Or before asking him, do you have any concern? Can you please summarize to me what did we get from this? Okay, doctor, you told me that I'm at the last line treatment of heart failure, a device called CRTD, and that it will improve my symptoms and it will protect me from sudden heart attacks, and that it's a one-day surgery. It will be done by a specialized physician, and it will be done under local numbness. It has some complications, but they are rare. And you will, and finally, you will follow up me and you will give me this magnetic, this card. Okay. Did I forget to ask you about anything, Mr. Robinson? No, thank you, doctor. Do you have any other? Do you have any concern for me? Yes, doctor. Why you don't send me to heart transplantation? Oh, I'm so sorry for this. I will review my consultant, but for my knowledge, the heart transplantation is confined to a specific group of people which are less than 50-year-old. And then the next word, you don't tell him, in older people like you, they shouldn't receive it. Don't say to him, in older people like you, because imagine you are telling him you are an old man. This is a hard word for the patient, for any of us. If you are telling him you are an old man, this is not good. And imagine if the examiner as well was an old man, and imagine if the examiner was an old female. Okay, and thus you are telling the patient that you are an old man, and no, just tell him in your age group. It is not studied till now, but the studies are the age group up to 50, and it have special preconditions. I need to go back to them to discuss this issue with my consultant. I don't have full details about this, but what I know, it's confined to specific group. Okay, do you have other concern? No, I don't have other concern. One last thing I want to tell you. Sorry, I forgot to tell you before, but I need to tell you as well. This device works in about 60% in patients. So we are expecting that you will improve by about 60%. You will be from the 60. We hope that you will be from the 60% patients that improves. 40% of the patient, they are unfortunate, and we don't know why. They don't respond to the device, and they keep suffering from shortness of breath. I'm so sorry for this. But protection from sudden heart attack happens. But I'm talking about the people who are not improving. They are called, by the way, doctors, non-responders to CRT, non-responders to CRT. Okay, is it clear? Okay. It seems that I talk more than 12 minutes in talking, but because I'm explaining the things to you, and I'm doing the surrogate and the examiner at the same time. Okay. Imagine, doctor, if you have time, still you are having time in station 4. Don't keep silent. Don't keep silent. Invent any issue with the patient. What are the issues that you will invent with the patient? Smoking. Tell him, you are a smoker? Yes, doctor. Would you like me to talk with you about smoking and the harms of smoking? Yes, and then keep talking about smoking. Okay, it will help him, and it's inside his situation, because you will not be silent. You shouldn't be silent. The other thing, Dr. Abdullah, I want to tell you, yes, one thing, I wrote it here. I forgot it. Okay, if I remember it, I will take it again. It's okay. Oh yes, don't tell the examiner that I didn't have time. Because when you are telling him, I don't have time, you are accusing the Royal College. They don't give you time. No, they are giving us the time, okay? Especially in these stations. Don't tell him I didn't have a time. Tell him I should. For example, did you ask about his history? What's the history? Don't tell him, oh, because of the time. No, tell him I should have. One word. If you get arguing with him, no, I didn't have time because the scenario was long or whatever, they will take bad impression about you. Okay. So again, doctors, very rapidly and in brief, when you are going to discuss a procedure for the patient, you should tell him, firstly, definition about this procedure. Okay. And then who will do the procedure? And then where it will be done? In the operation room, in the cath lab, or where? Okay. Then start with benefits. And some procedures have more than one benefit. Okay, like here in CRTD. And then don't forget to talk about before, I mean preparation for any procedure. This is easy to remember, inshallah. And then during the procedure, here you will explain the procedure completely. And then post the procedure or after the procedure. And after the procedure, okay, you need to, after the procedure, when the discharge will be, when the follow-up will be, will you need to give him something on discharge, like card in this patient, okay, like bags if he is having colostomy bags, okay, like a dressing if he will come from a very far place and he doesn't want to come again. So this is how to, this is briefly, this is very brief how to discuss, sorry, how to explain a procedure for the patient. Is it okay, doctors? Do you have any questions about this issue, because we have to move to the next case? Doctors, if any doctor want to want to ask any question, is most or she is most welcome. Yes, Dr. Hanan, go on. You are unmuted, Dr. Hanan.
No, me for the second case, I said.
Dr. Hanan for the next case. Type. Let me check, because there was one doctor, his or her name was Dr. Taiba or Taiba. She asked this early morning to discuss the case. If she is not here, I will see who wrote that, who or she wants. Yes, yes, yes. There is one doctor asked for the case, Dr. Hanan. Her name is Dr. Nafisa. I'm sorry, Dr. Hanan. If Dr. Nafisa is here, she can take the case. Is it okay with you, Dr. Hanan? Because she asked it first, okay? I feel there are too many things to cover within 20 minutes in this scenario. Okay, Dr. Salah, so you think that I took so much time in this case? You think like this? Okay, Dr. Nafisa, I will take you. So, Dr. Sarah, you think that we took so much time in explaining things for this patient? I'm waiting you. Yes, doctor. It's okay, doctor. We can finish the case within 5 minutes. I will repeat to you very rapidly. Hello, Mr. Stewart. Hello, I'm Dr. Khalid, one of the medical doctors here in the clinic. Is it Mr. Still Robinson? Yes. Okay, Mr. Still Robinson. Can you please, doctors, calculate the time for me, because I will show you. It's taking so much time because I'm explaining and writing and things like this. Okay. Okay, Mr. Robinson. You are 75-year-old. Yes. How are you today? Are you okay? Okay. Thank you, doctor. Mr. Robertson, we are here today to discuss your condition. Is it okay with you? Yes, doctor. Can you please tell me more what happened, what you know about your condition? Doctor, for the last for the last 7 years, I had cabbage, and then after cabbage, I started to have some shortness of breath, and after shortness of breath, I became more fatigable than before, and then they told me I am on optimal or maximum medical therapy, and then they called me 3 days ago to come and discuss a new line treatment. It will help me. Okay, that's good. I'm so sorry for what happening to you, Mr. Robertson, but yes, the consultant, your heart consultant, decided that there is a device should be inserted to you. This device is called CRT. Did you hear before about this device? No. Okay, if you would like, I can explain to you. then started drawing. So this device is called CRT, CRTG. So it's called cardiac resynchronization. Assalamu alaikum. Sorry, doctors, I don't know what happened. Okay, sorry. Doctors, do you hear me now? Sorry. No, I don't know what happens. What happened? Sorry. Okay. Okay, doctors, can you hear me now? I don't know what happened. Sudden shutdown of the program. Now, okay, thank you. So, okay, I will continue. Where did I stop? Okay, so this device is called CRT, where, did you hear before about this? No, doctor, I didn't hear. Okay, I will tell you. It's a CRTD, okay? Because, you know, in patients with heart failure, like you, the muscle fibers of the heart, because the heart is a muscle, the muscle fibers of the heart contracting, not contracting at the same time, so that the blood pumped to our organs are not our organs are not receiving the sufficient amount. That's why you are feeling fatigable and shortness of breath. What happened? This device is called resynchronization. It makes the muscle fibers contracts again at the same time, so they will push good amount of blood to our organs, so that you will not feel, or to your organs, so that you will not feel this fatigability. Okay, is it okay till now, Mr. Robertson? Okay, I will move to the next part of the device, which is called defibrillator, because, you know, patients with low pumping power of the heart, they are at risk of having abnormal heartbeats. Abnormal heartbeat, they can be fatal at any time. If it is in the hospital, we can manage by giving shocks. If you watched films before, you know, did you saw it before? It's like this. But if it happens at the home, you don't have at your home the facility or the person who will do this. So this device having a sensor inside it, if you felt any abnormal beat, immediately it will give this shock to you. Okay? Okay. Is it okay with you till now? Okay. Then we are expecting this device to improve your quality of life, your shortness of breath, and then also to improve the fatigability and prevent the sudden stoppage of your heart. Okay, is it okay with you? Okay. It will be done by a well-trained consultant, which is specialized in this area of medicine, and it will be done in the catheterization laboratory, which is a heart laboratory. It will be you will come fasting 6 hours before the procedure, and then you will clean the area, which will be the upper left part of your chest. You will shave this area, and then we will give you a prophylactic antibiotic, that's to prevent any contamination with the bugs, as per the hospital protocol. Is it okay till now? This is before, okay? Let's come to talk about during. What happened? We will, the consultant will give you an injection under your skin to make the area numb, so that you will not feel any pain. And then he will make a small, nice incision, and then he will get access to a big blood conduit to insert 3 soft wire. They are ultra soft wire. They will not break you. They will not make you feel any pain. Okay. Then 3 wires are attached to a battery. Then, after informing that everything is okay, he will close the suture. Not clear. Oh, oops. Allah, not clear. Lost again. Doctors, you can hear me now? I'm just repeating to tell Dr. Sarah that it will not take too much time. Do you hear me now, doctors? Should I change my network? Doctors, can you hear? Okay. Yes? Okay, doctor. If you cannot hear me now at any time, just please. Okay. So, Mr. Robinson, then after making that sure that everything is going okay, we will close this this suture. okay, sorry, this incision, and you know it will be done, and you will be awake, you will not feel anything. Sometimes we need to give some sedation for some patients, but usually we don't give. Okay, is it okay with you till now? Okay, the procedure takes about from 1 to 2 hours, mostly from 1 to 2 hours. After finishing the procedure, we will give you painkiller if you felt pain at any time, and proper antibiotics will be given to you according to the hospital policy, just for prevention. And then we have some precautions. If the procedure was done from the left side, and this is the usual place, don't elevate your shoulder above, your hand above your shoulder level. Don't carry heavy objects with this, and don't sleep on the left side. The discharge will be on the next day, mostly if things went okay. And after the procedure, I have to tell you that we do chest X-ray for most of the patient, to imaging of the chest, I mean, to make sure that the device is in its place and no air leakage around the lung. Everything is clear till now? Do you want me to explain anything from the words that I said? No, doctor. Okay, after discharge, you will be following up in the dressing clinic after 3 to 4 days, and we'll arrange a meeting within the next month for you with the heart consultant. Okay, and we is it okay for you till now? Yes, it's okay, doctor. Okay, Mr. Robinson, as you know, everything may have drawbacks, complications. I mean, so complications may happen like bugs contamination in the incision. Despite we will take our precautions about this, and we'll give you a proper antibiotic. And number two, some bleed around it, and we will take care about the wound very carefully. And also we will see you within the next 3 days to make sure that everything is okay. Or sometimes, you know, these are wires, and despite being ultra soft, the perforation of the heart may happen. I'm so sorry for this. And the collection of blood around the heart may occur, which is very dangerous if happened. And the last thing, abnormal heartbeats may occur. They are very fatal. But you know, this complication, despite being dangerous, but the rate of occurrence is very low, extremely low, less than one every 1,000 cases, and usually they don't happen. And if they happen, we will intervene with them very rapidly. Okay. Okay, is it okay with you till now? It's okay, doctor. Okay, so there are some things I need to tell you. We will give you a follow-up appointment with us after the procedure, and we'll give you a card. This card is very important if you are traveling. What's your job, please? I'm a businessman. Okay, it will help you so much, because you know, if you are going, if you are going through the gate in the airport, the magnetic gate, it will keep alarming because you are carrying a metal inside your body. So if you show this card to the security, they will be they know that there are some type of patients having this device, and they will let you pass smoothly. Okay, is it okay with you till now? Okay, do you agree for the things, Mr. Okay, can you please summarize what happened? Okay, doctor, I came with heart failure and I am on the optimal medical therapy, and you told me that I need a device that will improve my symptoms, and then it will improve my prevent the sudden stoppage of my heart, and I need to come fasting. I should make shaving, and then you make incision and you insert a battery, a device, and then I will be discharged mostly on the next day, and you will give me a follow-up and the card. Okay, thank you. Do you have any concern for me? Okay, doctor, if you calculated this minutes, total of 5 to 6 minutes, 5 to 6 minutes. This is the way, because you know you will have time. Even if you watch any video talking about station 4, specifically station 4, you are having a lot of time in station 4. Unlike station 2 or station 5, station 4 you are having a time. So this session, doctor, will be recorded, and you can calculate the number of the minutes that me and the patient discussed, including the minutes that I had connection error problem. Doctors, everything is okay? Dr. Sarah, are you satisfied now? Okay. So that doctors, please, who are taking online courses, or welcome, Dr. Asar, or doctors who are taking clinical courses, and all of us should receive online, and also this this clinical courses, please, 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 you should have a study partner. You should have a study partner and practice with him or with her every day to be more fluent. You know, you cannot say, you cannot explain the diagnosis very rapidly, very fast, very fluent, as Dr. Abdullah did, except if you are practicing every day or every other day. You should. Okay, Dr. Sarah? Okay, doctors. So we will move to the next case because I don't want you to lose your time. Dr. Sarah, we will take the next case. Sorry, Dr. Nafisa. Dr. Nafisa, you are with us? Dr. Nafisa? Assalamu alaikum. Dr. Nafisa. Doctors, do you hear me? Doctors, do you hear me, doctors? Regarding Blavix and we shouldn't stop only in this, shouldn't, no doctors, no, no doctors. Aspirin and Blavix shouldn't be started, except if the consultant asked it for. Except if the consultant, doctors, if anyone want to ask question by voice, he can raise his hand. It's okay. Okay. Okay, Dr. Nafisa. Doctor, the only medication that you should ask about, and I forgot to ask about that, is the warfarin and and this novel oral anticoagulants. Okay, they should be stopped. These, you know, I will tell you something. Some guidelines say that you should do it with INR 1.7, and some consultants leave it 2-3. Imagine the INR. So it's a variable. So if you ask it by the patient, tell him that usually it's up to 1.7 or 1.8, but I'll go back to my consultant to know what the preferable INR for you. Don't be shy to say this. Okay, Dr. Nafisa, please raise your hand, Dr. Nafisa, to be on the top. Okay. Mrs. Jilly Rocketly, she is 37-year-old lady. This is a station 2 doctor, huh? History station. Came with uncontrolled hypertension. Please see and answer any concern. Dr. Nafisa, can you please raise your hand? Okay. Dr. Nafisa, you are unmuted now. You can talk. Dr. Nafisa, do you hear me? Interrupted voice. Okay, doctors, I will just change my network now, sorry. The problem from my side. I'm so sorry. Sorry, doctors, I will change my network. Give me a few moments. I'm changing it now. I'm so sorry, Allah. Dr. Nafisa, prepare yourself, please. The scenario is in front of you. Okay, doctors, can you please tell me if my voice is better now or no?
Now is good, but يعني هو interrupted مرة كده ومرة كده، بس الآن كويس.
Sorry,
It's good now.
Because I have 2 networks. My first network was not working well. I'm so sorry for this. I didn't change it. Okay, Dr. Nafisa, when you are ready, just tell me. The scenario is on the dashboard. History station.
Yes, sir. Yes, doctor. Yes.
Yes? You are ready?
Mm.
Okay, doctor. Go
Inshallah.
on.
Hello.
Hello?
I am Dr. Jasmine, one of senior officer in the medical department. Nice to meet you.
Nice to meet you, doctor. Thank you.
I am talking to Mrs. Jelly, 37 years old. Is that right?
Yes, that's it.
Okay. Miss Jelly, I received a letter from your general practitioner. He stated that you have uncontrolled hypertension, uncontrolled high blood pressure. Is that right?
Yes, doctor.
Okay. All right. Mrs. Jelly, we will. We will make a discussion. I will take with you, and I will take few notes. Okay. I will write it, and be sure that all it will be confidential. And while we are talking, it will be confidential. All right.
Okay.
What is the problem with you? What is the problem?
You know, doctor, for the last 7 months, I started to have high blood pressure. And my GB started me on amlodipine, 5 milligrams. And then for the last 2 months, checked my blood pressure again. And then he increased the dose to 10 milligrams. And still my blood pressure is not controlled. You know, doctor, I'm okay. I'm feeling okay in myself, but I don't know why it's uncontrolled.
I am sorry for that. You have any complaint right now? You are feeling anything?
Feeling anything like what?
Like headache, any
No.
problem in your vision?
No, doctor.
And
I hear that hypertension causes headache, but I don't have anything. I have no complaint.
sorry, when first he diagnosed you as hypertension, it is incidental diagnosis, or by what complaint you went to him and he diagnosed you hypertension?
No, doctor. See, I'm an athlete, you know, and before going into any racing championship, they take, you know, they measure our height, our weight, our blood pressure, everything, and then they found my blood pressure is elevated, and then they recommended me to go to the doctor. That's what happened. So it was accidentally.
All right, Mrs. Julie. Okay, I will ask you some questions. You have any problem in your vision, in your sight?
Vision? No.
No. Okay. You feel any weakness in any side of your body?
Weakness? No, I don't feel weakness.
Okay. Any numbness in your body?
No.
In your limbs?
No.
Okay. Any heart racing?
Racing of my heart? No, doctor.
Any chest pain?
No, I don't.
You have any cough?
Any cough? No.
Any shortness of breath?
No.
You have any tummy pain?
Tummy pain? No, I don't have.
All right. And you have any altered bowel habit?
Altered bowel habit? No, doctor. I'm doing okay. I have no problem.
All right. And you have any change in your water work?
No, never. I don't have.
Any frost urine?
No.
And you tell this when this high blood pressure for the last 7 months it is diagnosed. And you have any other history of note?
History of what?
Any history of not you have high blood sugar, like high blood sugar?
I didn't check actually for my blood sugar before, so I don't know.
All right. You have any history you want me to be aware of?
Like what?
You have any like cardiac problem before, any problem in your
Cardiac?
kidney? Your,
What's cardiac, doctor?
sorry, I am sorry for that. I mean, any problem in your heart, Mrs. Jolie?
No, you know, I'm an athlete, doctor. You know, an athlete. I don't feel anything in my heart. My heart is okay.
Oh, all right. In your family, you have any family history of high blood pressure?
Yes, doctor. My mom is having high blood pressure, and my dad as well.
Do you know at what age your mom or your dad they have blood pressure? Below, in other meaning, below 40 years old or more than 40 years old, they get high blood pressure?
High blood pressure? No, maybe for the last 6 months or sorry, 6 years or 7 years only, doctor. My mom is about 70-year-old and my dad 75.
Right. Any family history of high blood sugar?
Family history of high blood sugar? No.
Any history of not in the family?
Like what, doctor?
Family history of sudden death in the family, early heart attack,
Nothing
or
like this.
high cholesterol in the family.
No.
All right. Mrs. Julie, do you smoke?
Yes, doctor, sometimes.
How much cigarette per day?
You know, I'm not that heavy smoker. Sometimes I smoke 5 cigarettes per day. Sometimes no cigarettes. Sometimes 15 cigarettes. I'm a moody person. I know.
All right. Do you drink alcohol?
Alcohol occasionally.
All right. And I will ask you some private questions that I ask. It will help. Maybe it's not related to the to your health status, but it will help me in reach a diagnosis. Are you married? Are you in long-term relationship, Mrs. Jolie?
No, doctor. I was married before and I'm divorced now.
All right. You are not using the bills for stop bill. You are not using this bills stop contraceptive bills?
Because I am not in any relations, so why to use this pills?
All right. And what about your what are you doing for your living?
Sorry?
What are you do for living?
I'm a businesswoman, doctor. You know, I'm a businesswoman. I travel, I go and come, you know. I have company in Brazil. I travel there and come like this.
And is it stressful?
Yes, for sure, doctor.
How much?
Very stressful.
How much? Is this your high blood pressure affect your daily activity and your job?
No. I'm completely. I don't feel any symptoms at all. I don't feel any symptoms. I don't know why the GB insisted me to come, despite I don't have any symptoms.
And what is your medication? Can you show me your medication list, Mrs. Julie?
Yes, doctor, I'm using amlodipine, 10
yes.
milligrams. It was 5 milligrams, and I increased it to 10 milligrams 2 months ago.
Only one medicine?
Yes.
All right. Are you compliant to your medicine?
You get to the point, doctor. Usually, you know, I'm traveling, going and coming. You know, I sometimes forget taking my medicine, and sometimes sometimes I don't care because you know I don't feel anything. Why should I take it? Why? I don't know. You know. So
All right.
I'm not welcome.
All right. All right, Mrs. Julie. And last reading for your blood pressure. Do you remember the reading?
It was 160 like this. Yes, 160.
And you are in regular checkup with your general practitioner for checking this blood pressure?
No, doctor, I'm not in regular follow-up with my medication. I'm not, I don't, you know, I don't like to go to my GB, but yes,
All
I was
right.
3 months ago, yes.
All right. Mrs. Julie, you have any increase on your weight?
Weight
You
increase?
have any weight gain?
No,
There is weight gain?
no.
No. All right. And Mrs. Julie, what's your concern?
I'm concerned about this blood pressure, doctor. What is the cause of this blood pressure? I don't know what is the cause and why it is uncontrolled.
All right. I highly appreciate your concern, Mrs. Julie. From our discussion, most probably you have what is a medical condition termed essential hypertension. You see that, you know that this is high blood pressure can
2
be
minutes remaining.
either
Okay.
all right. Can be primary, we can tell primary or secondary hypertension. Secondary, it means there is a cause behind it. Most probably from this condition, there is no secondary, there is no cause from this brief discussion behind. Most probably it is essential hypertension. This is one thing. The other things, you are not compliant with your medications. That why, and this is a serious problem, that you are not compliant with your high blood pressure. And if it is not controlled, it can lead to a serious complications like heart attack and stroke. So you have to be controlled. Meanwhile, I strongly advise you to be compliant with medication, and we will do more blood tests and imaging for you to and I will we will arrange another meeting to discuss the result.
Okay. So you will increase the medication to me, doctor, or what?
No. You see, this this is a maximum dose of medicine. We can give you another if it is not controlled till now. We can build up. We can give you another medicine. Another medicine, 2 drugs. Now we are using 1 drug. It is not controlled. We can give you another second line of treatment. But the most important, you have to be compliant with taking the medicine regular. And meanwhile, we have to do another blood test and imaging to see exactly is it what is behind for this high blood pressure, because it because the main cause of hypertension it will
time. Okay. Okay, doctor. So what was the cause of this patient's high blood pressure?
Most probably from the brief discussion, it is essential hypertension. It's not secondary.
Okay. What about the periods of this lady being a female? What about the periods?
Oh, yeah, it comes to mind. Then I forget to ask, but it is in mind, but I forget.
She may be having PCO, for example, polycystic ovary. Sometimes it can cause this hypertension. Okay, doctor. This patient, what about her past history? She was admitted before to any hospital?
I didn't ask, but I think I asked her anything.
Don't think, don't imagine. Don't imagine, please, doctor.
Okay.
Okay.
Because I asked her any, okay, I am sorry, but I asked her any past history of no.
Doctor, please don't argue with the examiner. I should have finished. Did you ask her about her any blood transfusion before?
No.
Okay. Any operations before she had?
No, I didn't ask.
Okay. What about her mood, doctor? Is she depressed or what?
Mood, I didn't ask also mood, about her mood.
Oh, okay, doctor. Do you think that educating hypertensive patients about smoking cessation is important or no?
Yes, important.
Okay, okay. So you discussed this issue with her, or you did not?
I didn't discuss the education.
Okay. What about her salt intake? Is it more? Is it less? Or what?
Okay. Also, this I didn't ask.
Is she using any illicit medications, illicit drugs? Sorry.
No, I didn't ask.
Or herbal medicine, being an athlete. Herbal medicine, for example. Okay.
Yes, I didn't ask.
Okay. How will you manage? Okay. How will you manage this patient, doctor?
Most probably I will give her, because of the age, I will give her ACE inhibitors, not calcium channel blockers.
Okay. So you think that GP didn't give her the correct medication, that's why her blood pressure is not controlled? Okay, what else, doctor, will you give her?
If not controlled, I can build up the medicine. I will give the second line and the third medicine. If not controlled, if after I give X3 medicine not controlled, I will refer her to special.
What else you would like to do for this patient?
I will refer her if after 3 medicine and she is compliance. First, I will hardly restrict her to be compliant to medicine. Then after that, I will give the second medicine and the third medicine. If after 3 medicine she is still not controlled, I will refer her.
What else you would like to do for her?
Investigation wise, I would do for her basic investigation, looking for her hemoglobin and mainly
hemoglobin. Is hemoglobin important in cases of hypertension?
Yes, I will see if hemoglobin high, it will give clue of polycythemia.
Did you ask her about manifestations of polycythemia?
No.
Thank you. I'm so sorry, Dr. Nafisa, for this, but I should do like this. Okay, we should be both under stress.
Okay.
See, doctor, he will not bring a case for you in the exam, hypertension, just to tell him that this is an essential hypertension. The hypertension is having an approach. This patient came with uncontrolled hypertension. So you did well in the beginning. Confirm the age of doctors. We will have a mind map for hypertension. It will make, inshallah, everything easy, and you will reach the diagnosis very easily, inshallah. So this patient came to you with hypertension. You should confirm the age. We said before, doctors, please, doctors, please. Doctors who attended with us the previous sessions, you will receive a blank paper outside in station 2. Please divide it like this, doctors. please. We said here, differential diagnosis. Please, doctor, write the causes of hypertension here. Doctors, we go systematically in reviewing the system from above down if we don't have a plan for differential diagnosis. If we have a plan for differential diagnosis, we will go with the plan of the differential diagnosis and then review the system that we did not ask about. Here we will write the ICE plus management. And again, doctors, we are not chemists. Management, pharmacological and non-pharmacological. Please don't forget the non-pharmacological doctors in any case. This is very important. And the one may lose the station because he didn't talk about non-pharmacological treatment of this hypertension. And here we said that we will write here the positive data. What is the impressive positive data for this patient? Hypertensive patient? Non-compliance?
Yes.
Okay, stressful life. He will tell you, you will get this point from inside, okay? Here, we said that here, we'll write CRB, fast, WT. And we said, you will take this paper with you inside the exam station. And you will read from it in front of the examiner and in front of the surrogate. And you will not be blamed for this, don't worry. Don't worry at all. You can read from it. Then, inside this, C for what? Complain.
Complaint.
Doctors who didn't attend with us before, you can write. C for complain. R for review of other systems. B for past history. F for family history. A, allergy. You didn't ask about allergy. S for social history. And social history includes alcohol, smoking, hobbies, bets, and illicit or herbal medications. Don't forget this line, doctor. The clue can be in this line, okay? Not here only, in other diseases. For example, patient with having new monkey at his home. He may be having extrinsic allergic alveolitis and he came to you with lung fibrosis or this shortness of breath, okay? S for sexual history. S for psychological history. Psychological. S again for smoking, because we forget it. T for travel history. T for temperature. W for weight. Review, we said here, complaint. How to analyze a complaint? Onset, course, duration, what increase, what decrease, association, effect of treatment, and the date of last attack. This should be explained on all complaints. And if it is painful, you should use the mnemonic Socrates for analysis of pain. And who attended with us before, and you can see it on YouTube. What's Socrates? ES here, ES, okay? Then, some diseases like hypertension does not have symptoms, so ask him about the onset. You can play with the things. Onset, when did it start? 7 months ago. Of course, you can ask about, did you find that your blood pressure controlled or no? Not controlled. What increase, what decrease, nothing will work here. It's associated with any shortness of breath, chest pain, or blah, blah, blah. Then you will ask about differential diagnosis, doctor, okay? Treatment. Did you receive treatment for this? Okay. Did it work well with you? Yes or no. Are you compliant? Yes or no. Did you use, what is the dose? Here, doctor, the problem is that you asked about the medication in the drug history down. I'm 100% sure. If I didn't tell you some word because I told you some word, then you remembered to ask about the medication history. So the medication history, doctor, you can bring it from here and from here, from the past history. And smoking about it twice, here and here, so as not to forget it. Two important things, here and here. Okay, date of last attack, it will not work here. Then come to review of other systems. Doctors, review of other systems equals differential diagnosis, plus asking about symptoms from above down if you didn't ask about them. Okay, so when you are reviewing other systems, you are searching for the cause of this hypertension. So you have to use the differential diagnosis before bringing things from above down. Okay, imagine in the exam you forgot to what is the differential diagnosis of this disease. Okay, bring the systems from above down. But if you have a differential diagnosis and you remember it, use it. It will facilitate the things for you. In past history, don't ask him only, do you have past history of disease? He will tell you no. And then you will move to the family history. Doctor, please prepare, please train yourself. Do you have any past history? Do you have any past history of chronic diseases? No. Any hospital admission? No. Any blood transfusion? No. Do you have any past history of, we said blood transfusion, hospital admission, chronic diseases? Do you have any past history of medications you are using? No. Okay. Then come to the family history of similar conditions of consanguinity, if you are suspecting inherited diseases. Okay. Then allergy. Do you have any allergy to food or medications? No. Now you in your mind you have the plan. Please, doctor, if we are planning to do history stations in the future, inshallah, and you inshallah will do, please, it will not take from you 2 minutes only to prepare yourself like this, and you will cover all the things. And inside the exam, don't be shy to write on the thing you finished. So I asked about this past history, yes, because you took permission already from the patient to write. So this is okay. Family history is, I asked about family history. After finishing, look at the paper, allergy. Then after allergy, I cover the social history. And then, okay, till you finish all the things. Okay, doctor, I repeat this part in all the sessions. So I will talk now about approach for the patient with hypertension. Number one, doctor, after confirming the age, because the age is important, please, doctor, please. In the paper that I show you, which is like this in the previous, here, up here, please write it down. Or even you can write it in the positive data here. In this patient, for example, male, 60-year-old or 37, or female 37. She was a female 37. Why? Because this will affect the management plan, and this will affect the management plan. If she is more than 55-year-old, the plan will be changed. If she is male or not a female, the plan will be changed. So put it in the positive data, better than putting it up. Okay? And how to approach the patient with hypertension, doctors? You have to ask him a few questions before going to asking about the cause of his or her hypertension. So I asked him, since when, and when the last time did you check? So when did it start? And last time you checked for the blood pressure, and what was the reading at this time? Then ask him, are you using a medication? Yes. Controlled, compliant? Yes. Controlled? Yes or no? This is in any disease. Okay. Are you on any lifestyle modifications? You can ask it here. He will tell you yes or no. Then ask him about complications, doctor. You didn't ask the patient about complications in hypertension. You asked in a very sporadic way. But you should ask him about 3 things. What are the 3 things that you should ask about the patients with hypertension? Ask him about complications. Ask him about diabetes. You asked about it, doctor. Good. But you didn't tell the patient that we will check your diabetes. Okay. and ask him about the fat in his blood, fats in his blood. You asked about the high cholesterol in the family, but you didn't ask if he checked himself his blood cholesterol or no. This is very important. This is very important. So complications from above down. Did you check your eye before? No. Fundoscopy. Did you check your heart before? Sorry, heart before? No. ECG and echo. Here fundoscopy. Did you check your kidney function before? No. Albumin creatinine ratio and blood in urine. Blood in urine. This tests doctors are routine in any hypertensive patient. It should be done. This is for searching for complication, fundoscopy. ECG for searching for complication as well, LVH. Echo to search for a complication or a cause, because if this patient is having coarctation of the aorta, he will have hypertension and it will appear on the echo. And the kidney, you should check for ECR and blood in urine. Then come to the next step, which are the causes of hypertension. The good thing, you take the good approach, doctor, but you didn't complete it. So what is the mind map for causes of hypertension? Patient came with hypertension. You will ask him about his weight, because his weight may be affected by any of three ways. Hypertensive patient with weight loss, hypertensive patient with weight gain, or hypertensive patient with no weight change. Hypertensive patient with weight loss, low weight gain, or no weight change. So if it is weight loss, three hypers. Hyperthyroidism causes hypertension with weight loss. Hyperparathyroidism, because the calcium causes hypertension and weight loss by the time. And hyperadrenalism. What is hyperadrenalism, doctors? Pheochromocytoma. Pheochromocytoma. So three causes of hypertension with weight loss: hyperthyroidism, hyperparathyroidism, and pheochromocytoma. And automatically, if you found, you can write on the chat box, if you found the case of hyperparathyroidism, what will you search for, doctor? What will you search for? Doctors, you can write on the chat box. If you found hyperparathyroidism, you will search for what? Hello? Hyperadrenalism. Yes. I mean, hyperadrenalism is a Cushing, or even hyperadrenalism can be this this as well, pheochromocytoma, you know, because these are parts of the adrenal gland. But just to remember, hyperadrenalism. Okay, I mean high adrenaline, doctor. Hyperadrenalism, high adrenaline. That's to simplify the things. Yes, men, excellent, doctor. Excellent, Dr. Nafis. If you found hyper para, you will search for men. What if you found this pheochromocytoma, high adrenaline, you will search for what? What else you will search for if you found pheochromocytoma? You can say, Dr. Amaro, you can say men. Yes. What else happens with pheochromocytoma association? Okay. To save your time, doctors, if you found a patient with pheochromocytoma, I mean high adrenaline, you will ask him about three things. Do you have any skin rash? What is the cause of skin rash and pheochromocytoma? Excellent. Which type of neurofibromatosis, Dr. Abdullah? Which type? 1 or 2? 1. If he is having skin rash, think about neurofibromatosis type 1 and then go with it. If he is having an eye problem, what is the cause of pheochromocytoma and eye problem? Problem in his vision. von Hippel-Lindau disease. Excellent, Dr. Abdullah. Okay, and then by the way, von Hippel-Lindau disease will have neurological manifestations as neurofibromatosis. But the most important here is skin rash, and the most important here is eye problem. The third, if you found, sorry, there is no skin rash and no eye problem, so think about men. So any case of pheochromocytoma, you should ask, do you have any skin rash? No. Do you have any eye problem? No. Then ask about men. Don't be confined to men only in case of pheochromocytoma, because you know von Hippel-Lindau syndrome, it is not uncommon. It happens 1 to 35,000 case. So this is not uncommon. Okay. So if you found the case of pheochromocytoma, hyperadrenaline, you should ask skin rash, neurofibromatosis type 1, eye problem, von Hippel-Lindau syndrome, and then ask about any affection of the urine, affection of his, any weakness. Plus, it can cause renal cell carcinoma, this von Hippel-Lindau syndrome. And by the way, von Hippel-Lindau, 3 numbers, it comes on the chromosome number 3. Then the patient came with weight gain. What are the causes of hypertension with weight gain? You know, there is transportation company in Saudi Arabia called Septico. Anyone working or living in Saudi Arabia know that there is a company called Septico. It's a transportation company. So remember, Septico for to carry people with weight gain. Just to remember it. Okay, I tried to make a mnemonic or find a mnemonic that will work easily, but I actually couldn't find easier than this. So S for steroid, A for acromegaly, B for pregnancy, preeclampsia, doctors, don't forget it. Okay, and it came a case before, by the way, but I cannot remember where exactly. Pregnancy or polycystic ovary disease. No, hyperthyroidism, doctor, can cause weight loss, not weight gain. Okay. T for thyroid, which is, I'm sure that Dr. Sarah means hypothyroidism here. It came here. Okay. C for Cushing. O for obesity and obstructive sleep apnea. And if you found obstructive sleep, if you found obesity, you should ask about 3 things: carpal tunnel syndrome. Any weight gain, doctor, usually, any weight gain generally, ask about 3 things: manifestations of carpal tunnel syndrome, okay, osteoarthritis, and obstructive sleep apnea. Okay, doctors? So, Septico causes weight gain with hypertension. No weight gain, so it will have another mnemonic. You can arrange the mnemonic as you want. برقم. Raqam in Arabic means number. Okay? Or you can make it cramp as you like. You know, you can play with the mnemonic. You can make it cramp as you like. So the first B for what? Polycythemia rubra vera. R, renal causes of hypertension. What are the renal causes of hypertension, doctors? Polycystic kidney disease, glomerulonephritis, excellent. And nephritis, yes, by the way. And renal artery stenosis. Most importantly, fibromuscular dysplasia, female, young age, deteriorated after taking ACE inhibitor. It's not only a renal artery stenosis, it can be a fibromuscular dysplasia. It happens in middle-aged female like this lady. And the diagnosis of fibromuscular dysplasia or renal artery stenosis by MRA, magnetic resonance angiography. The artery will be beaded like this. Okay. Then what else? M for medications. What are sorry, still the K. K for potassium. K for potassium, which is hypokalemia. What are the manifestations of hypokalemia, doctors? I will write them up here. Weakness. You remember the periodic paralysis can cause weakness, yes? Weakness, muscle cramps, plus or minus arrhythmias. Okay, so what are the causes of hypokalemia? CLL, CLL. C for cons, hyperaldosteronism. Yes, twitches. L, Lidl. L, licorice. Licorice. It came a case before doctor. The patient was a driver and he was consuming large amounts of licorice. And then this was the case. Okay. Then medications. What are the medications that cause hypertension? Lots of medications, doctor. Steroids, non-steroids, non-steroidals I mean, oral contraceptive pills, cyclosporin and his brother is a tacrolimus, okay? Cyclosporin and his brother, tacrolimus, diet medications like sibutramine, decongestants, but not the nasal, the oral, and it came a case before in Malta. Patient was having sinusitis for a prolonged period. And by the way, doctor, if you found in the past history, yes, phenylephrine, and if you found in the past history the patient is having a disease, ask him about this disease. For example, if he told you, I'm having a sinusitis, oh, I'm so sorry for this. It's annoying you or controlled with medications or no, with medications. And then you can keep it, pick it up from here. What else? Medications, you should add here herbals. Herbals, like ephedra. It's something like ephedrine. And this was the case, doctors. She is an athlete. And you told her how they checked her blood, how she discovered that she is hypertensive. She was planning to go to a racing championship and they found her hypertensive and then they pushed her to her GB. Okay? If you ask her about any illicit drugs or herbals, she will tell you, yes, doctor, I'm using ephedra. You know, ephedra, it improves the performance of the athletes so that they receive it. And sometimes they check the level for it. So you have to take care about this. This is the cause of her hypertension plus non-compliance. And she is still practicing this one. Okay? So doctor, I think it will be easy now, inshallah. I think it will be easy now. Because now you will ask the 3 or 4, yes, cocaine for sure, cocaine for sure, cocaine. Oh yes. So now patient came with hypertension, you will ask him rapidly for how long you are, how old are you, for how long you are having this hypertension, are you using any medication, is it controlled or no, what are your medication, what are your jobs, are you compliant on this, didn't mention white coat hypertension. I'm talking about the causes of hypertension. This is generally, this is a differential diagnosis of hypertension. Other things you can pick it from the past history. Doctor, see, when we divide the things into differential diagnosis, this is a differential diagnosis. After finishing the differential diagnosis, you can pick, if you didn't find the diagnosis here, the A for acromegaly, doctor, A for acromegaly. Okay? Sorry, I forgot to write it. So Dr. S, okay. So if you didn't find your diagnosis in this differential diagnosis, mostly you can pick it from the past history or from from the drug history or the family history. You can pick it. If you couldn't pick it, you can mention in your management plan, or you can ask the patient directly. Did you notice that your blood pressure comes higher when you come to the clinic? or before you come to the hospital, she will tell you yes or no. Okay, but she told you, but there is something happened in her history that mostly exclude white coat hypertension, which is she was in the racing championship and they discovered that she is hypertensive. Okay, but this is a good point. We were planning to come to it in the next few moments. So again, doctor, how to reach the case of hypertension rapidly? For how long you are having this problem? Last time did you check for your blood pressure? What was your reading? Is it controlled on medications? What are the medications? What are the doses? Are you compliant with them? Are you on any lifestyle medications? No. Okay, I'm going to ask you very rapid questions, but just I need answer yes or no from you. Is it okay with you? Okay, doctor. Do you have any eye problem or you checked your eye before? No. Do you have any heart problem like shortness of breath? No. Chest pain? No. Racing of your heartbeats? No. Do you have? Did you check your kidney function before? No. Do you have any frothy urine? No. Any loin pain? No. Did you check for diabetes before? No. Did you check for lipid profile before, or this fats in your blood? No. Okay. So can you please tell me about your weight? Like you are having weight loss, weight gain, or no change on your weight? No, doctor, I don't have any change on my weight. Despite I sometimes use the, you know, I sometimes try to lose my weight because I'm an athlete, but I don't have weight loss associated with this high blood pressure. Okay, I'm just going to ask you rapid questions. Can you please tell me more? Do you have any continuous headache? Do you feel itchy after taking a hot bath? No, doctor, I don't have. That's good. Did you notice that your facial features changed? No. Did you notice there is a change in the size of your head or your ring? No, or your shoes? No, or your necklace? No. Do you have an old photo? Can I have a look at it if it's present with you and if it is okay with you? No, doctor, my face didn't change. Okay. Did you have any continuous headache since you were a child? You are asking about early childhood or adulthood. You are asking about polycystic kidney disease. Do you have any family history of hemorrhage inside the brain before? No. Do you have any loin pain or flanks pain? No. Okay. Do you have any frothy urine? No, doctor, I don't have. Any blood in your urine? No. Do you have any? Did you notice any shortness of breath that happened to you all of a sudden? Because sometimes in artery stenosis causes flash pulmonary edema. Okay. Or did you notice that did you check for kidney functions before, and you found it deteriorated after a specific medication if your patient was taking ACE inhibitor? No, doctor. Okay. Did you feel any muscle weakness and cramps with occasionally you feel that you are paralyzed sometimes or you cannot move? No, doctor, I don't feel like this. Do you drink licorice so much? Or no, doctor, I don't like it. Can you please tell me what are your medications? I'm using blah, blah, blah. Are you using any Profen? Ask by name, doctor. Ask by name, please. Ask by name, because we consider it as an OTC medication, and they, you know, like OCBs. In females, if you ask it here, are you using any medications? She will tell you no, because they don't consider OCBs as a medication. So you should ask about OCBs by name, and some cases Profen by name. Okay, are you using any illicit medication or herbal medicine? Yes, doctor. I'm sorry to tell you this, but I'm using ephedra. Now you got the case, doctor. See how it is very easy, inshallah, to get the case. What I want from you, doctors, now, to make scenarios from this mind map and to train with a study partner about this. For example, put a case in your mind, patient with PCO, for example, and ask your colleague came with hypertension and start discussing with him and make notes from him. The good things he did and the bad things who did or she did. Okay, it will facilitate the things and will make you more fluent and fluent. Okay, and I will remove this. I will remove this slide, doctor, because I have to write other things. Don't worry, I know that we talk so much today, but I'm about to finish. I don't want you to say that I'm a bad man. Okay, now doctors, now imagine this patient, we took it as a history station. Hypertension can come as a station 2, station 4, and station 5. Okay? Sometimes it can come as a station 5, and if it came to you as a station 5, you should reach the diagnosis rapid. If you didn't find any cause from this, finally you tell her, I'm so sorry, I couldn't find any cause for your high blood pressure. I will talk to my consultant about this. If there is any hidden causes I couldn't reach, or if we didn't find, we will consider it as an essential hypertension. Don't worry to say this. And tell the examiner like this, sorry sir, I couldn't find any, don't say sorry. Sir, I couldn't find any cause of this high blood pressure to consider it as secondary hypertension. However, more investigations need to be done, because we shouldn't rely only on the history. We should do full investigations to exclude secondary causes of hypertension, because if there is a secondary cause of hypertension which may be treatable, the patient may become normotensive again. So doctor, if a patient came to you in station 5 as hypertension, please write on the chat box, what will you examine? Because patient in station 5 came with hypertension, you ask yourself, what should I examine? You can write on the chat box, doctors, please. Hand, okay. Abdominal berwi, excellent. Pulse, okay. Neck thyroid, excellent. Rate rhythm, proximal myopathy, xanthelasma, fundus, excellent, Dr. Sarah. Fundus, cardio, excellent, Dr. Abdullah. Very important, very important. Start from above down, doctor. You will examine the fundus. Offer to examine the fundus. Say, I'd like to examine the fundus. He will tell you no need. If you told me no need, it's okay, better. Okay? Then go down to the neck. I will examine your neck rapidly. I will examine the gland in your neck rapidly. And then examine, as we said in the first lecture, doctor, and you can find it on YouTube, how to examine the thyroid gland EDB in the upper limb and the ETB in the lower limb, and then the thyroid gland. You can go back to the first lecture, you can find it on YouTube, doctor. Radiofemoral drainable pulse. Okay, we'll make it easy, doctors. You can bring it from above down. I for fundoscopy. Offer to do fundoscopy for him. You can see dot hemorrhage and this plot hemorrhage and silver wiring as well, and EV nipping and EV nicking. This is the fundus in this patient. What else? Go down a little bit. The thyroid gland. You should examine the thyroid gland if you have time. If you don't have time, go directly fundoscopy and target it to the heart. Okay. Plus the pulse, you should examine the pulse. No, and you can talk to the patient while examining. And then the abdomen, as you said, for abdominal puree, okay, or the kidneys, if you are suspecting polycystic kidney disease, and the lower limbs for edema, okay. So if you would like to choose systems from this and the time is chasing you, endoscopy and the heart plus the pulse, very important. This is very important. Why you will examine the heart in patient with this hypertension? because he may be having aortic coarctation, and it's the cause of his hypertension. And you'll hear ejection systolic murmur, like aortic stenosis. Yes, but radiating to the back. Huh? The difference here, this is radiating to the back, unlike aortic stenosis radiating to the neck, the base of the neck. Okay, or it can cause a complication like heart failure, like aortic regurg. Hypertension causes aortic regurg by the time, doctors, if not uncontrolled. And here you will hear the systolic murmur. So you should ask your patient to sit down. Okay. MVR, aortic stenosis. Aortic stenosis does not lead to hypertension. Aortic stenosis decreases the blood pressure by the time. Okay. So there is nothing inside the heart itself can cause hypertension. All causes of hypertension outside the heart. And the nearest one to the heart is a coarctation of the aorta. This is the nearest one to the heart. Okay. So you have to examine the heart, and you have to examine fundoscopy, and you have to offer these things to the patient. And you should tell him in the management plan. So this patient in the management plan, what will you tell him? You will tell him, we need to do some tests and some imaging to you to search for the cause of this high blood pressure. We should start you on lifestyle modifications, and doctor, please start talking about lifestyle modifications. Mrs. Kelly, I need to talk to you about the lifestyle modification because it has a very beneficial impact on controlling blood pressure. I will tell you approximate numbers because I cannot remember the accurate numbers for this, Mrs. Kelly. But for example, if someone is smoking and he stopped smoking completely, his blood pressure will go down by about 7 to 8 numbers after 1 month without any medications. Imagine. So if the blood pressure is initially 160 and she just stopped smoking, you are expecting her blood pressure after 1 month to be 153 without medication. The other thing, to decrease the salt in your diets. Usually we need 10 grams of salt per day, but if we reduce it to 5 or 6 grams per day salt, we are expecting blood pressure to go down by 2 to 3 numbers after 1 month. So imagine 10 numbers drop in the blood pressure without single tablet. Other thing, if the patient's lifestyle is sedentary, you should encourage him to do exercises and start walking, brisk walking. The recommended is brisk walking. The usual walking does not lower blood pressure. And for me, I didn't read that it's written in the guidelines. But what's written in all guidelines, that brisk walking is the recommended thing. And it can lower the blood pressure by about from 3 to 5. If you started doing exercises for 3 to 5 numbers, imagine. Plus, if she is drinking alcohol, if you stop alcohol, you are expecting your blood pressure to go down by 3 numbers. So we are talking about nearly from 15 to 17 numbers drop in blood pressure after 1 month without single tablet. So now, doctor, why I mentioned the numbers? Because now you know that lifestyle modification is very important. If you didn't lifestyle modifications in the hypertension station, the station may be lost completely, because this is a part of the treatment. And even you can treat your patient without giving him single tablet. Okay. Okay. So then come to the management. When please, doctor, when the examiner asks you about management of any disease, put it in your mind: acute or chronic, or acute or non-acute presentation. In any disease, for example, you have a case of myasthenia gravis and they ask you how to manage. Tell him if it's an acute condition or non-acute condition. The management is different. Okay. If the patient came with, for example, hypertension, tell him, is it acute or not acute? I mean, is it hypertensive emergency or hypertensive urgency? If he came with very high blood pressure. or just high blood pressure, 150, 160. So what's the difference between hypertensive emergency and urgency? By the way, doctor, these are the questions of the examiners. Don't think that hypertension, you know, I will tell you something, doctor. We study the clinical cases and we forget a case like this, hypertension. And then you find in the exam, your case is hypertension. And then he will keep asking you about lifestyle modification and how to manage hypertension and how to treat hypertension. And then you get blocked. No, it's very easy. If he came in hypertensive urgency, I will not admit him, even if his blood pressure 400. Doctor, please don't admit patient to your hospital to manage hypertension except if he is in hypertensive emergency. And hypertensive emergency means that there is an end organ damage. What's meant by end organ damage? From above down. Hypertensive encephalopathy, acute pulmonary edema, malignant hypertension, I mean causing visual problem, papillary edema and hemorrhage, okay? Aortic dissection, or patient came with eclampsia. These are the hypertensive crises. I mean the hypertensive emergency that needs admission. But if your patient came with blood, for example, if patient came with blood pressure 180 over 120 and is having acute pulmonary edema, you will admit him. Other patient came with blood pressure 230 over 120 without symptoms, don't admit him. So you don't depend on the number in admission. You depend only on the this end organ damage. Again, so the patient came with end organ damage. With hypertensive emergency. I need to admit him and monitor his blood pressure closely, either invasive or non-invasive. And according to the guidelines, we have to lower the blood pressure. Doctor, this is the question of the examiner if your case is hypertension in station 5 or Herstel station. How to lower the blood pressure in hypertensive emergency? You can write on the chat box, doctors, if you would like. How to lower the blood pressure in cases of hypertensive emergency. If you didn't answer this question well to the examiner, it will have a very bad impact on you. Okay, I don't want you to lose your time. I will save your time and tell you. I will write it, doctors, okay? Because we may forget it. I will write it here. Patient came with hypertensive emergency. I mean end organ damage. How to lower the blood pressure? Decrease the blood pressure. Which blood pressure, doctors? Systolic or diastolic? Labetalol? No, doctor. Okay, I will tell you. Lower the blood pressure by 20% in the first hour. Doctor, this is the guidelines, the nice guidelines, okay? In the first hour, lower the blood pressure by 20% in the first hour. Then, by 5 to 15% in the next 23 hours. So, after 1 day, you should decrease his blood pressure by about 35%. This is my question, Dr. Abdullah. Which blood pressure you are aiming to lower? Systolic, diastolic, or MAB? MAB, main arterial pressure. We are looking at the MAB, not for the systolic and not for the diastolic. We are aiming to decrease the MAB, main arterial pressure. And then here comes the question of the examiner. Because he will ask you basic questions. What is the MAB? This is the mean arterial pressure, which is the diastolic blood pressure plus 1/3 of the pulse pressure. The pulse pressure is the difference between systole and diastole, okay? Okay, so decrease the blood pressure by 20% in the first hour, then by 5 to 15 in the next 23 hours. So total of 35 hours within 35% in the first 24 hours. Okay. This rule is valid except in 3 conditions. Number 1, oh sorry, by the way, hypertensive emergency blood pressure 180 over 120, or some others say 110. Okay, this is hypertensive emergency except in eclampsia 160. Okay, 160 the systolic. Okay, so this rule is valid except in in 2 conditions. Number 1, aortic dissection. Imagine, doctor, in aortic dissection, we should lower the blood. We should aim at achieving systolic blood pressure. Systolic blood pressure 120 within 20 minutes. Imagine patient came you within 20 minutes, you should lower his blood pressure up to 120 in aortic dissection after 20 minutes only, because the aorta is being teared. You have no time. You will not wait for 24 hours. He will die. Okay. What if he had a stroke? Stroke, what should I do? He will die from aortic dissection. Okay. The second is the ischemic stroke. If you cannot remember these things, doctor, no need to remember everything. Just tell him that this rule is valid except in aortic dissection, because we need to lower the blood pressure much more rapidly. And in ischemic stroke, I have to activate the stroke code. Stroke code. Yeah? Stroke code. This is like the blue code in some hospital. Stroke code. Or I have to contact the stroke team because they have their blood pressure. But usually, if you wanted to know, doctor, what is the answer for this? See, if the patient, I'm talking about ischemic stroke, okay? If the patient is candidate for thrombolysis, I mean you will do thrombolysis for him, don't lower his blood pressure except if his blood pressure 185 over 110. If you will do thrombolysis for him. If no thrombolysis is planned for him, so lower his blood pressure if it is more than 220 over 110. Okay? How to lower? With this rule as well. If you want to know the medications, it's up to you. Labetalol, sodium labetalol in hypertensive encephalopathy. Here, sodium nitroprusside. Okay. If you want to know, it's okay. If no, nothing, at least you have to know the broad lines. How to? This is the most important, doctor, in all of them. How to measure the blood pressure in cases of hypertensive emergency. We are aiming to decrease the MAB by 20% in the first hour, then by 5 to 15% in the next 24 hours. Okay, doctors. Last thing I will tell you. I know that all of us are tired now. Young patient with hypertension, think about renal or coarctation of the aorta or essential hypertension. Hypertension plus neuro manifestations, think about neurofibromatosis type 1, polycystic kidney disease, and von Hippel-Lindau disease. Last thing, ambulatory blood pressure monitoring. Ambulatory blood pressure monitoring for patients with suspected white coat hypertension, not only for white coat hypertension, but also to diagnose the to see if your patient is controlled on your medications or no, and to see another thing called the Deber and the non-Deber, if you want to know it, Deber and the non-Deber, because usually our blood pressure should dip, I mean go down when we are sleeping. If it goes down while the patient is sleeping, it means that he is not at high risk of a stroke. If it is non-Deber, I mean does not decrease during sleeping, he is at high risk of stroke. If you want to know this, but however, ambulatory blood pressure monitoring, how to interpret? I mean how to say that your patient is hypertensive based on ambulatory blood pressure. You know, doctors, the guidelines, the new guidelines was released in August 2019. They made some change. Okay, So the ambulatory blood pressure, if your patient is more than 80-year-old, you can say that he is hypertensive if his ambulatory blood pressure more than 145/85. If he is less than 80-year-old, he is hypertensive if his blood pressure more than 1 or equal to 135/85. So the difference only 10. Okay. Last question from the examiner. How many readings of the ambulatory blood pressure you will consider it to be valid? Tell him at least 14 readings should be valid. And at least 2 readings in his working hours. Okay? Till now we came to the end of this session. I hope that all of us get good benefit. If I forgot anything, just please remind me on WhatsApp group. I'll be very happy if you remind me about anything. Doctors, if any of our colleagues have any question, you can unmute yourself and ask the question before finishing this session. If you don't have, we can say Assalamu alaikum and we can finish the station. And inshallah, it will be uploaded on the YouTube channel. And hope to see you soon, inshallah. Thank you, doctors, very much. May you please give comprehensive list of possible cases of each station. This is a big issue, big. At least you see, doctor, no one single course will cover, no one like most frequently asked cases. Okay, doctors, the cases that usually I present this are cases mostly from the last diet or the last few diets. For example, we had a lecture or a session. I don't like the word lecture. We had a session about itching. You will find it on YouTube, on our channel on YouTube. We discussed the causes of itching, and the cause was a non-Hodgkin lymphoma. You will find it. A case of hypertension came before, and the patient was using glucose, and we said about this. And the patient came before hypertensive, and he was using decongestant most of the time. Okay. So if we will try to concentrate on the cases that they come already, inshallah. But no single course can cover all the things, Dr. By the way. But at least you have to know how the life is going. Yes, Dr. Salma, go on. What's your question? Go on. There is no case in communications coming in which a young lady diagnosed with multiple sclerosis. One case, multiple sclerosis is very common. Thank you, Dr. Vino. No, multiple sclerosis very common. There is one case, communication skills coming in which a young lady diagnosed with multiple sclerosis, very common scenario, by the way. Okay, very common scenario. Yes. That I told you. Okay. Maybe still you didn't ask your question. And the examiner is asking why you refer to SHO. Okay. The healthcare system in UK is different, not a little bit, is different from our countries because they have a primary health cares. Primary health cares plays central role in helping the tertiary centers. So multiple sclerosis and usually receiving this TNF blockers, they receive it in the tertiary centers, by the way. usually the follow-up of symptoms, of side effects, such things, usually it can be seen by the GP, okay? And the multiple sclerosis is a common case. So the GP should have an idea about this, okay? And the SHO, again to SHO. Okay, sorry, see, I cannot answer. If you have the scenario, we can read, because usually he will write the task. Usually he will write the task. For example, you are in SHO, you discuss the side effects of the medication. Okay. He will write the task, why they refer the patient to you, or what's your responsibility. I didn't see the scenario, but I can tell you what happened. One of the colleagues entered the station in one station, and the examiner told him, "Doctor, did you read your task outside?" So maybe, I don't know what happened with this station that you said, but I have to know why they asked it. Maybe to discuss the diagnosis and plan of management. It should have been already discussed by the neurologist, but the follow-up, I think, of the side effects and the medications and the blah 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 should be by the GP. I will search for it and I will ask, and if I got an answer for this, I will get you. But if you can give me the full scenario, it will be more helpful. Station 4, a patient recently diagnosed MS and explained by neurologist, but patient wants to meet Dr. Meet here and explain her concern. I can explain most of things. Patients is not much issue. The problem is the examiner asked me why this patient needs to meet you, even explained, but I cannot answer this question. I asked patient, but she said, I just want to know more. So I did not ask details, but examiner specifically asked, so it may be hidden agenda. But no, see the patient, here comes the answer, doctor. The patient tells him, I want to know more. So for sure, see, the candidate said, I didn't explain more. Yes, the problem is the examiner asked me why. I cannot answer the question. I asked the patient, but she just said, I want to know more. So I didn't ask detail. She wants to know more, so he should ask for detail. What do you want to know? If you want me to discuss the things again with you, I have no problem. It's my pleasure. Okay, so no, nothing like this. Yani, if the patient if the surrogate will not tell you from where you will get the things, okay, he should have asked about what's his concern, why he wants to see him. Maybe he wants to see him because the bed is not clean, for example. Okay, so I think he should have asked him why he wants to see a doctor, and if he wants to see this doctor, he is happy to explain anything to him if he wants so. Okay. Okay, doctor. Inshallah, see you soon. بإذن الله. Assalamu alaikum wa rahmatullahi wa barakatuh.